Hi, this is QD Clinic, and I'm Jack Cush with Room Now. QD Clinic is brought to you by Room Now Live, coming up in March, 3 weeks away. This is about integrating new data into your practice. Be there. Today's case is a 54-year-old woman with psoriasis and joint pain, and the dermatologist wants to know, do I refer the patient? So in my meeting notes, I'm going to give you a nice link that you can look at, written by Alexis Ogden and others, but I think that there's several things that need to be considered when confronted with this case. As you know, up to a third of patients with psoriasis may develop psoriatic arthritis. We tweeted just the other day or this week that nail disease is associated with psoriatic arthritis. Actually, no, it's not nail pitting. It's onycholysis and nail dystrophy that actually has a better predictive value. Some debate about that. But if you have a psoriasis patient, they're likely to have arthritis if they have worse skin disease, if they do have nail disease, mainly onycholysis, if they have enthesitis and dactylitis, or if they have inflammatory back pain. So the differential diagnosis of a psoriasis patient who has joint pain could be to run straight to psoriatic arthritis for the cause, but in fact, no. The more likely thing is what we see in consults is osteoarthritis, age-related, and typical osteoarthritis joints, fibromyalgia, sleeping bad, feeling bad, lots of fatigue and joint pain, but nothing to show for it. I mean, their joints don't look that bad. They could also get gout. Psoriasis has higher levels of uric acid, and that does equate to more attacks of gout and or nephrolithiasis. So these are the things that you want to look for. The question is, do you refer? Any of those would be a good reason. Chronicity of complaints, meaning I like joint pain and swelling going on 12 weeks more than 6 weeks, but 6 weeks is a good enough one. An abnormal lab. But you now have to advise what the evaluation is with the dermatologist and whether or not they want to refer. So joint pain more than 6 weeks, the presence of any of those other findings I talked about, dactylitis, enthesitis, inflammatory back pain, persistent joint swelling, especially if it's in but a few joints, and I mean squishy swelling, and then morning stiffness that's inflammatory, meaning more than 45 minutes. Any of those would be a good enough reason for referral. What about labs? They shouldn't order the ANA 1000. That doesn't make any sense, right? I mean, they should order simple lab, CBC, chem profile. I don't usually do uric acid until they have an established diagnosis of psoriatic arthritis or psoriasis. That's problematic. I do like getting and recommend getting sed-rate and C-reactive protein. If there's any confusion because of the number of joints that are swollen, then a rheumatoid factor and a CCP antibody should be done. LFTs would make sense. What about the rest? ANA? No. There's no overlap between psoriasis, psoriatic arthritis, and anything that looks like lupus or autoimmune. And if you're confusing that, then go ahead and refer it. The rheumatologist will figure it out, but an ANA is useless in this situation. LFTs are often worth getting because psoriatics have a lot of comorbidity, a lot of fatty liver, and that's pretty much all I need to receive a consultation. Once I receive the patient, and if I'm going to treat the patient, I may or may not get imaging. If they have chronic swollen joints, I'm going to get imaging to see if they have any evidence of erosions. But I'm not generally doing a whole lot of imaging tests. I almost never would do an MR or an ultrasound unless I was ultrasound happy. I do have an ultrasound machine, but I don't use it unless I'm looking for enthesitis and the patient has enthesitis. I want to see what it looks like. I can feel good about my skills. It's kind of easy to find tendinitis and enthesitis on ultrasound. MRI, no. I think later on, after I've established the diagnosis, I do want to get Hep B surface antigen, maybe the panel, which is a surface antibody, and a core antibody can tell you about current or past hepatitis B infection. Hepatitis C antibody makes a lot of sense, and that's about it, unless you're going to go on to a biologic that may require TB testing in the form of either a PPD or an IGRA. That's a gamma interferon releasing assay like the TB spot or the quantiferon assay. And that's pretty much the evaluation that we need to get started on therapy, which starts pretty basic: anti-inflammatory, no use of steroids, early use of methotrexate, maybe instead using a Primolast. Most of us don't use hydroxychloroquine. And then with severity of disease, we'll consider other therapies. And that's basically the message for another QD clinic. Tune in for more QD clinics. We'll see you at rheumnow.live.